So these are the acronyms that are commonly used in medication portion of asthma care. Understanding the language of lungs and the acronyms and treatments is important not only for us to have professional conversations with our peers and with the healthcare provider fields that are outside of schools. Families that have children with chronic health conditions are not only experts on their children, they are oftentimes experts, to the good or the bad, on the treatment of children and the care of children. And I have found in my experience that when they come into a school, they are sometimes ahead of where I am in that particular chronic illness if I haven't experienced it or I haven't had someone with that specific disease in a while, because a school nurse becomes an expert the second they get a child with a specific disorder, whether that's a common one like asthma and allergies and diabetes and seizure management, or it's something less common. You have about 15 minutes to become that expert. So this is one of the challenges we're facing. I'd like you to take a look at the list and see if these are familiar to you, if these are brand new, but these will help us as we go through the rest of the presentation. And I will be using acronyms because one thing I'll tell you, I don't know who makes up the names for these things, but they are very difficult. So I'm going to try and enunciate and speak slowly, and we'll get through that, and you might learn some new acronyms along the way. So time and knowledge. These are the banes of anything, of any industry, of life. We don't have not enough knowledge in asthma management as a school nurse. We actually have too much knowledge. Keeping up with all the different evidence-based guidelines and resources and where to go is extremely time consuming. And one of the problems that I've found in supporting schools, both as my time as director of the New York State Center for School Health and now as a consultant, is time is golden. And that a lot of times, because you're so busy doing, you don't have time to learn. And instead of professional development being a habit that's built into the day, it becomes a fire drill that creates stress all around. So one of the things I'd like you to think about in your head is whether it's through contractual setups with your school, is building in some time where you can sit down with peers on your own and take that time to help make sure that your knowledge isn't gapped, that you are where you need to be. So nurses not only have to be up on their game on the clinical protocols, the most current science-based information on care and treatments and nursing process, they have to live in a different country. And that country is called the school world. And it's almost like going to France. You have to understand French and you have to understand the culture of France to be able to be successful. These are some of the other non-specific clinical pieces that school health people have to be aware of in creating the support that they provide in the school. School nurses are basically community health experts, and your community is the school. Most public schools across the US are local control, meaning that their local board of education makes the policies and rules that happen in school. I'm sure there's many other people on this call who've experienced parents saying to them, but I can do it at home. Why can't you do it in school? And that's part of this whole process. So helping people understand that is really important. All 50 states and the District of Columbia allow students to self-carry and self-administer their prescribed albuterol medication, but it does require compliance with district policies and state laws around prescribing, the Nurse Practice Act, who can train, who can approve that. There's an authorization. The student has to be competent. School nurses often find that what a student can do in the quiet confines of a medical practice is not what the student can do in their, in their own office. So there are self-direction guides that can be used. The American Lung Association has absolutely fabulous resources that school nurses can use and adapt and adopt to help them make the determinations of whether the student is competent in the school setting, so they can have further discussions with families and with healthcare providers. Thank you, Stephanie. So we talked about too much to read and too little time to do it. And this slide indicates the 4 major areas of what would provide you with the information to ensure that you are at the top of your game. So we have the 2025 Global Initiative for Asthma, called GINA. These are the summary guidelines. The latest was published in 2025. They are updated every year. We have the 2020 National Heart, Lung, and Blood Institute 2020 focused updates. We have the National Association of School Nurses Asthma Clinical Practice Guideline and the Asthma Toolkit. And we have state asthma guidelines for schools. There are about a minimum of 7 states that have their own state asthma guidelines, which of course are specific for your laws within your state, your Nurse Practice Act, your Medical Practice Act. But all these things together take a lot of time. The Global Initiative for Asthma and the rest of this is very time consuming to read. So how can we get all this information in a concise manner? How do we know what we don't know, which is really part of the problem? And Stephanie, if you can move on to the next slide. In nursing school, there are 2 things that most people have engraved on their brain. And one of them is the 5 rights of medication, which you see across the top of this slide. This has been expanded in recent years because healthcare has changed, and healthcare is now more inclusive and collaborative with the patient. Part of this is because the way we approach healthcare has changed. I know when I go to my internal medicine provider, he often sits down and says, well, what do you think? This is part of this global change. Sometimes I think, well, you went to medical school. What do you think? I want more information. The drive in this was to increase safety, reduce risk, and ultimately provide the foundation for competency, allowing critical thinking by nurses across all venues, not just school nursing, to have this collaborative approach. So the right reason, the right response, the right documentation, the right education, and we do all this without thinking about it, and the right to refuse, which is part of any medication program. I want to point out that that right to refuse does not only apply to patients, it also applies to the healthcare practitioner. If you have a medication that you feel is an incorrect dose, an incorrect administration route, it is incumbent on a nurse to question and clarify that order prior to providing it. And that means that not only the patient has the right to refuse, but the school nurse as well. In New York State, where I am, nurses are not required to administer non-FDA approved medications. They may choose to do so with the appropriate documentation and conversation, but that's an example of where critical thinking comes in to make sure that everything is as safe as possible. Stephanie? The impact of asthma and the goals of asthma control in a summary nutshell to make things easy and quick. So asthma is the most common condition that we see in school. It varies between 2 to 3 students per class of the 30. When you do the math, 12 times 2, it's actually 2.5 students, but that student's probably got bigger issues than just asthma. Only half of them's there. Hopefully it's the upper half. Absenteeism was a problem prior to COVID. So this just adds additional layers to that and makes it much more difficult. You might remember that I mentioned that the GINA or that the updates came out in 2020. In 2020, a significant event occurred across the world, which changed a lot of things and how we think about healthcare. Because those guidelines came out in 2020, they have been slower to be impacting people because it slowed down uptake of those. So that was very significant as well. Absenteeism across the US is a national problem because kids aren't just missing air when they're absent, they're missing socialization and learning and confidence in going forward and managing their own health. Thank you, Stephanie. So symptom control, minimizing future risks, and improve quality of life. In a nutshell, that's our goal with asthma care. I love this slide, which was provided to me, and that's because what we see and what's actually going on are very, very different in terms of the impact and the scope. So the symptoms, what we see when the student presents to the health office or what they share with us subjectively when we ask them how they're doing, you can see is the smaller of this. And underneath all of that is the inflammation, the airway remodeling, and the airway obstruction. And the key piece of this, not only in prevention but in treatment, is that if people don't see the entire picture, medication adherence and compliance is impacted. This is very similar to what happens with hypertension or high blood sugar. All this injury is going on, but it's not known. So it's more difficult to collaborate with people and help them understand the importance of consistent medication use. Together, two documents provide the most current evidence-based treatment guidelines for asthma care. I mentioned the GINA summary guide before, and again, this is updated every year. But we also have this 2020 focused update to asthma management guidelines. And you can see that this was in part produced. If anyone has been in school nursing as long as me, you might remember the EPR3, which were the original guidelines for this. This is not updated every year, and the 2020 update was actually the first update in 13 years. These two documents are very similar though, in what they are sharing as best practice or other options to decrease asthma exacerbations going forward. And it was in part overseen by the National Asthma Education and Prevention Program, which was a fabulous resource that I used when I was in my clinical nursing practice. And again, due to COVID, it was slow for adoption. And they contain 6 key changes about asthma management. And we are going to talk about what those changes are. Thanks, Stephanie. This is part of what the changes produced, and that is a stepwise approach to asthma management, which indicates which medication should be used at which time and how often. This is part of one of the update pages. As school nurses, we are not prescribing. Is it helpful to understand what those steps are in helping you figure out the severity of a student's asthma based on the types of medications they're taking and how often they've been prescribed? Yes, but is this something that is maybe step 2 to understanding how the medication is delivered and how the medication works? I would say yes as well. But this is part of the 2020 focused updates. Stephanie? And this, in a nutshell, If you don't want to read the 205 pages of the updates and the 42 pages of the summary guidelines, is what it says. And this is very different from what I practice in school nursing. I typically only saw the reliever medications in school. Controller medications were kept at home, except when families confused the controller and the reliever medications and sent me in the wrong one, or I found out that they'd been using controller medication as a reliever medication the entire time that we've been working on the control. So I don't want to just read this to you because you certainly can see it, but I think the key thing for a school nurse is at every single med visit, we are running through the nursing process. We are asking about symptoms. We are asking about severity control, meaning with compliance, with adherence to their medication. Are they still having symptoms or are they not having symptoms? And side effects to the medication that they're taking, which can be significant. I will tell you one side effect that's not medication induced is the fact that middle schoolers particularly and high schoolers may not want to be seen with their inhaler or their valve holding chamber or device, and they simply don't tell anyone, particularly in sports. If they think they're not going to play and they pull out their inhaler, that is a side effect. It's a social side effect. And we're checking inhaler technique because 70 to 90% of people usually have some error in inhaler technique. And if the medication is not getting into the lungs, we are going to have a problem. Thank you, Stephanie. So let's talk about the asthma delivery devices and how they work and what they do. So the first thing we're going to talk about is how do they get in? How do they get into the body? And this is a generalized, there are a couple subgroups of these, but this is generalized. Meter dose inhalers, I think that's the one we're all familiar with. What we traditionally see is the albuterol. Then we have the dry powder inhalers, which don't require a spacer or valve holding chamber. We have the soft powder inhalers, and we have nebulizers. That is the how. That's the car. That's how we're getting to where we're going. Then we have, okay, what's in the car? What's going to happen when we get there? Those delivery devices, the action of use could either be a long-acting control medicine or a quick relief medication. And we'll talk a little bit more about that. This is the breakdown of what both of those types of medications do and how they do it. You can see that the timing of duration is different and how they're used is different. And of course, the mechanism itself is different. Thank you. So this chart is available on the website for the ALA. It is fabulous. It can serve multiple purposes. If you have someone who has an inhaler and wants to tell you what they're using at home, but doesn't have it with them, this can be a point look and choose, figuring out what that person is using. It also is a quick breakdown of what these do based on their mechanism of action. And it helps you explain what the medicine does once it is in the body. So again, we have the long-term medicines and we have the quick relief medicines that last those different times that we looked at in the previous slide. This is free, this is printable, and in my practice, I would have one of these, stick them in actually a page protector or have them laminated and kept them in my office. I found it very useful in working with families to help figure out what exactly they were taking and how often. This is the back side of that, or the second side, I should say, if you're printing it, of that same chart. And you can see it does give you the definitions. It talks about SMART, which we'll talk more about in a moment. And it also gives you additional links with QR codes to learn more. As I said, this is only one of probably 60 different resources on the American Lung Association website. that are available for your use. Wonderful and fabulous. If you are in New York, you might see the New York State Children's Asthma Initiative down there, which I said I was going to use nice guy. For New York folks, there are other things specific to New York, but could be extrapolated into other states. Both sites are great. I look at the American Lung Association as the mothership and Children's Asthma Initiative as one of the pods. When I was preparing this, I realized very quickly, we talked about the asthma journey, we talked about the acronyms. So I was working on this and talking to Farah Shatila, who is my contact with Director of Children's Asthma Initiative, and I used the word plastic thingy because for the life of me, I could not remember the word actuator, boot, jacket, or case. Now, case I should have had, but I was asthma. And I thought to myself, that is not going to be effective in talking to my peers. So I thought others might just value taking a quick rundown of what is an MDI made up of, what are the proper words, and what does each part do. So the information I'm sharing, I should have said this right off, I will be putting into a resource document that has been prepared with the ALA and NICE-Guy. I'll be adding specific school nursing pieces for you to go and do some further learning when it's convenient for you. Thank you, Stephanie. I talked about SMART before and the changes that came out in the guidelines. This is the biggest piece of this, that you use one inhaler every day to both prevent and treat, or you use a combination medicine that's taken at the same time. And I didn't mention that when you're looking, for the beta 2 agonist, you'll see that this is LABA, long acting, instead of SABA, which is short acting. The value of this is compliance. It is sometimes difficult to have someone be compliant with one medication a day. And if they're taking two, it can be even more difficult, especially when might be confusion over what those medications are doing. When the medications, when they go to the pharmacist and have the counseling, a lot of people defer that because medications look the same. It's in a actuator or jacket or boot, and they don't realize that the medication in the canister may be different. So that's really important to encourage them to do that counseling, or at least at point of visit when the medication is being taken, to do some discussion about how it works, when it works, and again, those side effects. Thank you, Stephanie. So one thing that happened when there was the change from the type of propellant that was in inhalers, I will age myself, but back in the day, we used to float an inhaler to try and figure out how much actual medication was left in it. We did not have dose counters, and using a hash mark system or trying to record it could be iffy because people forgot to do so. And with the change in the propellant, there was a change in how medication is stored in terms of the priming and how we use it. This describes what those changes are. And the impact for school nurses is, if someone is going on a field trip with an inhaler, it's critical that they understand that that inhaler, if it hasn't been used, it's per manufacturer's instructions, but if it hasn't been used typically within 40 days, if it's been dropped, it needs to be primed. And the primes could range from 2 to 4, depending on the type of brand that it is. But if you don't prime the medication, then you don't get a mix of propellant and medication itself, and you may only get propellant. And there have been student fatalities where unlicensed personnel did not have that information about the importance of the prime and shaking the medication, and a student was given two actuations, waited, gave them 2 actuations, there was no result. They did not realize that the student had never actually received medication. The student had only received propellant. So this is important to think about when you're educating those that you might students that are self-directed, that they understand what's really important. Of course, standing and sitting straight, pointing the inhaler towards the back of the throat is also very critical in terms of making sure that that medicine gets all the way down into the lungs. So this is a very, I think, helpful chart in showing what happens when you add a spacer or preferably a valved holding chamber to an MDI. Slowing down it's almost like the Three Bears. It can't be too slow. It can't be too fast. It has to be just right. And that's what a holding chamber, and again, a spacer, and preferably valved holding chamber does. It creates a space to inhale the medication. It creates a space to break down the size of the molecules so that they can go to the right space within the body. If you go on other sites like the American Allergy, Asthma, and Immunology site, they actually can show you by type of drug where they go due to the micron size of the molecules. And it's amazing. I mean, to be honest with you, I did not realize that the different brands or different types of medications had such different size molecules. So that makes a difference. But bottom line, sit up straight or stand up straight and use a device which helps make sure that you don't have to do this crazy coordination of spray, breathe, hold, much like bowling. It is very, very complex. And of course, the younger the student, the more coordination it is going to take. The other problem is, at least in my experiences, children rush. If you have someone on a pump or a CGM, you've seen this. They just whip through, put the wrong numbers in. Everybody wants to get out of that health office quickly or rush through this to get to the next thing. And people don't take the time that they need to make sure the medication can effectively get where it needs to go. And that is not helpful for anybody. So this is an example of spacers and valved holding chambers. If you are new to asthma management, the valved holding chamber has exactly that, a valve which creates a one-way flow of the medication out into the body, but not the body back into the device. And this would be the preference, that if you can counsel parents and guardians when they come in to say, here's your medication. I see you don't have a valved holding chamber or a spacer. That's a great discussion to have with your healthcare provider. That will make sure that all the medicine that's coming out of that device is getting into the body, and we can get the most of it as possible into the lungs, not the stomach, not the back of the throat, not the sides of the cheeks, and sometimes not even out into the health office environment. So this is a really, really critical piece, and is also part of the guidelines to help people understand why this is so important in providing best asthma care to get everything that they need. Thank you. So getting these spacers and valve holding chambers, one of the challenges is cost. And if anyone has bought gas recently, you can think, well, if we have spacers and valve holding chambers that can range from $10 to $25 a unit, and I want two, I want one for home and one for school, this can be difficult. So getting these in the office can be difficult. This product is a I'll say it is disposable because it lasts, it can be used for a week, but it is a cardboard valved holding chamber made by Thayer Pharmaceuticals. I actually use these in my practice. You could theoretically buy a case of these, and they are $132 for 25, which brings them down to about $5 a piece. If a school chose to, they could buy these and have them supplied for students whose healthcare provider wrote an order for their use. They are considered a medical device, And Thayer actually has just like EpiPen, has a medical order or medical ordering sheet, I should say, on their website that could be used for a school medical director to order these. A school would not need to do so, but the value of this is you would have them for students that could not or did not supply their own. The secondary advantage is many students who do have one in the health office do not have one in the coach's toolbox. So if you had the order and you had these in the toolbox, you would have that available for student athletes who now have their medication, but don't have this assistive device to make sure that the medication is getting where it needs to go. I will put all the information about this, should you choose to learn more about it, in the resources that I provide to the ALA. In my practice, the gold standard was a nebulizer because you could hook it up, you could see where it's going, and a nebulizer is great, but a nebulizer typically, unless you get a portable device, is not going to go on a field trip with you. And research has shown that a properly educated and practiced student using a valved holding chamber will get a similar efficacy of medication delivery to a nebulizer. So I used to concentrate really on getting the valve holding chamber and spending my time in education and practice, because at some point that student is going to go on a field trip. And by having the work put in on that item versus the nebulizer, which if that's what's ordered, then that's what we would do, just puts so much more flexibility at your fingertips and making sure that that student gets what they need when they are not in the health office. New York actually had a law requiring nebulizers. It was unfunded and was repealed. Sometimes parents will donate these to the health office. And of course, you might look at the mask. All of the valve holding chambers, or not all of them, but many of the valve holding chambers do have the option of the mask, which we'd want to make sure that the seal on any mask was tight and fitted, but that can be also addressed with a valve holding chamber. So how do we know if the medication's working? How do we know if the student is, how they're doing, basically? These tools are comparable to a thermometer. So you want to measure how much air can a student push out of their lungs in a fast blast, and these are two types of peak flow meters. Peak flow meter parameters are typically, they are on a asthma action plan, whether they're filled in on an action plan, so you know what's the lower parameter and what's the upper parameter, may not always be there, but it can be very helpful to have that information. Of course, then the student would need to have their own piece of equipment to do this measuring, but it can be a great visual for students, because they can see what they can blow. And for some students, it actually can be an incentivizing thing to help them look at that. We'll talk in a minute about what happens between anxiety and asthma. This can really kind of help to determine what's going on. So I do encourage you to encourage students to have this in their toolkit. We have a toolkit for asthma. Sometimes we only have a hammer, but we really need the screwdriver and the pliers and maybe the tape measure. Another assessment tool is a pulse ox. And I threw this slide in because I am on 3 different Facebook groups for school nurses, which are extremely valuable to me because I learn from others every day. I see things that I didn't even know about. I didn't even go learn about. It's a community of support, which is great for school nurses who are often isolated. The one caveat I'll say is that not everyone that posts into Facebook may have the most current information, again, because we don't know what we don't know. And sometimes information is posted with great confidence that I have been doing something else on, and I know that it may not be the most up to date. So if you do see things in a Facebook group, in a social media chat, I encourage you to trust but verify to make sure that that actually is, particularly around state guidance, because each state has its own Nurse Practice Act, and we do follow different rules for some of this. So in the Pulse Ox Facebook group, they talked about the readings. And if you are going to use Pulse Ox as another tool in the toolkit, you should have parameters for what to do with that information. It would be like having a glucometer and then not knowing what to do with the results. So also there are some caveats about what happens with cold skin, nail polish, pigmented skin color. These are all great things to be thinking about if you do use Pulse Ox. Asthma medication, it is a team sport. So pivotal is the school nurse, the people that are on this call today. These are not all the things you do. These are the minimum of things that you do to make sure that students can stay safe and healthy around their asthma medication. But it's not you alone. There are more people on your team. We have unlicensed school personnel, and depending on what state you're in, they have different abilities around medication delivery, depending on what your Nurse Practice Act talks about. We also have teaching staff who spend most of their time with the student, so they can understand how we can reduce triggers and reduce need for medication by education and maybe environmental adaptation. And the next slide. And then we have the parents and the guardians. So they really hold all the cards. They have to get the medication, they get the orders, they share consent. And I have expiration tracking on here, which is usually automatic when ordering through the pharmacy, because I know nurses are expiration tracking. But in eventuality, they are the final people taking care of of their children. So that is on them. Next slide. This is a map of stock albuterol across the US right now and the various states that that's in. It is a challenge to look at all the different parameters that go into this. You need a policy, you need legislation, you need to get the medication. The bottom line is stock albuterol saves lives because it allows you to have a backup for a student that does not have their individual medication in play. And it seems like a no-brainer if you have an order being able to get this medication, but this is government, and government takes time. Nurses can be advocates for this. Nurses can work through their state organizations. They can work through the National Association of School Nurses and advocate for students having the ability to have backup medication when it's needed. So asthma resources to support medication use. These are all of the places that you can go to find more information. And there are more than you probably have time to go to look at, but trying to bring this down, the ALA has a fabulous asthma resource library, including videos for almost every single type of medication, which can be helpful not only for students and families, for you as a practitioner. There's no way you can know 40 different medications. They have asthma management in schools. They have practical guidance for school districts, including a whole toolkit on how to get stock albuterol within your district and state. I can't tell you that if you have one resource to go to, the American Lung Association will be one-stop shop. And then if you're looking for New York State specific, or even if you're not, only because the American Lung Association has a brighter swath than asthma in schools. They have COPD, they have multiple resources, but the Children's Asthma Initiative is more focused, both excellent. Stephanie? So how to respond during an asthma episode, free, print it, download it, put it on the wall, give it to the teachers. Usually when people don't feel well, the first thing that unlicensed staff I'm not talking about health aides in your office. I'm talking about teaching staff, the bus driver. They tell you to lie down. Don't lie down. Don't lie down. Stand up, sit up. And this is a great guide because people that aren't familiar with an asthma emergency may not know what to do. This lays it out in a very quick step. Stephanie? There you go. 5 seconds of what to do. Asthma action plans are critical to safe and effective asthma care. Oftentimes, you might get an order on not an asthma action plan, and you need to send it back to the provider. The two that were initially on this slide are from the ALA, and they have one specific for schools, which has an area for you to put the physician or the healthcare provider's signature. If they need an attestation, it may need more than this. So it would be dependent on your state. Some states have their own asthma action plans. And the key is this is the cookbook. This tells you what needs to happen in a visual way. And if you can have the order be on one form, it's one less form to chase. It's one more way to create one total place where parents, families, and healthcare providers are on the same page. Is it difficult to get these? You bet it is. And one thing you can do is post whatever you want parents to complete on your district website. So they don't need you to give it to them. Then teach them that your health services page, hopefully on your website, is the hub. You are the place and the expert in your school to provide these. If it's on the website, they can go get the forms they need, this or anything else, during times when you're not in school over the summer, when parents typically get these things for the next school year. So I can't say enough that creating a space on your district website not only emphasizes your role in making sure they can come to and stay in school healthy, it changes the way that you interact, because now you're working in collaboration, much like that expanded 5 rights of medication. Stephanie? This is one of the resources on the ALA website. So we talked about healthcare providers, physicians, or other advanced practitioners being able to attest or authorize a student to self-carry and self-administer. As I mentioned, it can be a very different look in the confines of a quiet medical office versus a busy school or health office. This is a great tool. You can do it either online or you can print it and do it to ensure that students really can do what parents and healthcare providers think they can do. Because the downside is a student who is not capable of independently giving their own medication in an effective way isn't going to get the medication. So if you have a student that you find is not as competent as what they've been deemed to be, that conversation starts with the family, and then it can be inclusive of the healthcare provider, because the next step is, how do we get them there? This poster is a great resource. I don't know if anyone out there is coming into spring pacer season, where students have to do athletic running and push-ups and jump-ups to see what their fitness level is, typically done in full view of all other students. My health office, I had an 50% increase in students when the pacer was being run, because students were so anxious about performing in front of other students. I'm not talking about students who are diagnosed with asthma. I'm talking about all students would come down to the health office, those including those with a diagnosis of asthma. This is just a great quick read on some of the things you can kind of look at to say, what might I be dealing with here? And this is where the peak flow meter can also be very helpful in trying to figure out what's going on. In doubt, of course, we would provide medication, looking at the other tools of assessment that we have, but it can also create a great conversation to help students learn to understand their own body and how that works, and how they can use techniques to define this for themselves. Because ultimately, just like students are increasing their knowledge of reading and global history and math, we're trying to take them along the continuum to self-management of their asthma care. That's the gift we can help give them along with their families. Stephanie? As I mentioned, the American Lung Association and NICE, absolutely two great resources. And it's difficult. I already mentioned the 4 resources that you can go look at and read through. If you go to these 2 sites, they have really refined and drilled this down into need to know and where to get that information. And they've done the work for you. They've already made sure it's updated. They've already made sure that it's vetted for clinical evidence-based practice. So if you have a limited amount of time, the American Lung Association and NICE would be the 2 resources that I would put on my quick list, add to my favorites list in my browser, because you can get the right information at the right time and you can get it quickly. I asked why when I was preparing this, and this slide was presented to me. I said, well, how is this going to help a school nurse? I can see that it's for tobacco cessation and counselors and respiratory therapists. It does say nurses there, but I wasn't thinking school nurses. And in discussion, I realized when I have a question in the office, who am I going to go to? Who am I going to ask? I can ask a peer or a colleague, and they may have that information. So a school nurse can call the lung helpline and ask a question about a medication, about a symptom, about a side effect, about a technique or a resource that will help you help the students you care for. And I just don't think I realize this. The bigger piece is that they have Spanish-speaking staff and live interpretation, because I struggle with helping families to find information or to communicate information in the native language of families. It's hard enough to talk medical speak. It's impossible when you're trying to do it through the veil of not having that be your native language. So this was really great when I saw this. Stephanie? And practical tips. Hopefully you have some of your own. These were ones that I found helpful. As I mentioned, I would have students not only come with their brothers or sisters inhaler from last year once removed, but especially with either using a reliever and a controller in tandem, you want to know, well, what are they using at home? What is it supposed to do? Is it effective? So this can help. And of course, we have that chart. Use a Sharpie to label the medication canister and actuator, plastic jacket, because if the canister falls out of the actuator, you may not know. I've had teachers come back with like a shopping bag full of canisters. Where do they go? Sometimes the pharmacy will label both, but oftentimes they will not. So I would also put the expiration date right on both. It just makes it easier to keep track of it, and it's very visual. I, in my head, would also put the primes right on there if you're not using like a Ziploc bag to put the order in. If it doesn't have a dose counter, figure out how you're going to track those, especially in an EHR. It typically doesn't allow for the primes, so you may not have the actual count, because you will be using 2 to 4 primes if the medication's not used routinely or if it's dropped, and you want to know what that is. There are smartphone apps, and I'm thinking now we have a lot of bans in schools, but this would be a medical exemption that allows students that have that capability to track their symptoms and track their inhaler use. And it can be a great incentivizer for compliance and ensuring. A visual timer, think the type that you can measure for teeth, would be helpful as well. The National Association of School Nurses has a fabulous clinical practice guideline. They have an entire webinar on this. It has 6 sections with 45 resources, and this could be a district-wide PD day. This could be individual PD if that's part of your Nurse Practice Act requirements. You do not need NASN membership, or excuse me, you don't need a paid membership, you just need a membership. So this can be really good. And again, this is very, very helpful in terms of not having a fire drill, having planned PD information. Stephanie? The last thing I want to mention is almost all states, I think there are 43 now, 43 states have a national have a state school nurse consultant. And a state school nurse consultant's job is to be a resource and provider of updated information for the states that they serve. Some are in the Department of Health, some are in the Department of Education in your state, some have a foot in both camps. I will put the link for the National Association of State School Nurse Consultants in the resources, because if you don't know what your rules are in your state, this is a great place to start, as well as the resources specific to your state. Please utilize them because they provide a wealth of information at both the nursing side and the school implementation side. Thank you. I hope that you learned something useful, something you can take back and put into practice immediately, and appreciate the time that you took to spend time with me today. This will be recorded for those of you that want to go back and take another peek at things. And as I mentioned, I will provide resources that will come to you sometime in the next week or so, I believe, that will include my resources along with those that are available from the American Lung Association and NICE. Stephanie?
Yes, thank you so much, Linda. So we do have a question by Trina. Why do you need to reprime if an inhaler is dropped?
You know what? I do not know the answer to that. We do have some AECs, I believe, on this call. I was thinking about that as I was looking at this. You can see the non-use. That makes sense about the propellant. It's about the mixing of the propellant. So I don't know if they thought maybe the actuator would be dropped. Are there any AECs on the call that can answer that for us?
So as of now, I don't have the answer to that, but if I'm not sure, Cindy, I see that Cindy is also on our call. If you might have the answer, Cindy. If not, Trina, we can divide, come together with an answer and then send that out with our follow-up email with all the resources as well.
That's like a tidbit you could share at a party that no one will know because nobody
Yeah.
on the call knows it.
Yeah.
And I do have to say a shout out to Cindy. My asthma career started with Cindy in Rochester, New York. And it's just been such a great journey. And I have I have enjoyed learning so much. And hi, Cindy.
Thank you so much, Linda. So that was our only question, and I know we only have about a minute left, and I just wanted to quickly show that we still have 2 more webinars coming up. So we have a webinar next week about treating persistent asthma, putting patients on the right therapy using the stepwise charts. So if you would like to learn more about that, please join Dr. Callie Cyrilakis next week at noon as well. This is the QR code to register. In the previous slide, you can also scan this QR code to be taken directly to our American Lung Association website. And we do have a landing page for our Asthma Awareness Month webinars. And our last webinar, so after next week, we have one the week after, and 0.5 CMEs are available. So you have to attend live. So you have to attend that session from 12:15 to 1, and you can have 0.5 CMEs. Okay. Well, thank you so much, Linda, for everything. This was such an interesting webinar. Thank you for the wealth of knowledge that you have given to all of us. And thank you, everyone, for participating and sharing part of your afternoon with us. And like Linda mentioned, we will be sending the recording as well as a list of resources next week. Okay. Thank you so much, everyone. Have a beautiful day.
Thank you.
Thank you. Thank you.